Okay, so today's webinar will be moderated by our wonderful director, Dr. Sarah Walker. And so without further ado, I will turn this to Dr. Walker.
Thank you so much, Sally. I am so incredibly excited to be able to introduce our speakers today. It's a total win that we got them to speak on this webinar. I just want to note before we jump into that this is the first of a webinar series that CoLab will be doing this year. Our next one will be focused on cultural humility and evidence-based practices, and it'll be led by Dr. Wong Fong Johnson sometime January 2021. So we'll be sending out the date for that very soon. Go ahead and advance the slide, Sally. So in introducing our speakers today, I'm pleased to introduce Susan Kennedy, who's the director of Academy Health's Evidence-Informed State Health Policy Institute, where she manages the full portfolio of state-focused networks and projects. She's also the program director for the State University Partnership Learning Network, a learning network which works to collaboratively support evidence-based state health policy and practice with a focus on transforming Medicaid-based healthcare, including improving the patient experience with care, improving the health of populations, and reducing the per capita cost of healthcare. And in this capacity, she leads the Administrative Coordinating Center for the Medicaid Outcomes Distributed Research Network, which was established to enable cross-state Medicaid analyses to inform critical Medicaid policy and program decisions. And she is also the program director for the Medicaid Medical Directors Network, which is a learning network focused on the development and use of evidence-based medicine, measurement and improvement of healthcare quality, and the redesign of healthcare delivery systems. She received her MPP and MSW from the University of Michigan and completed professional program in health advocacy at the University of California, Berkeley. We are also incredibly pleased to have Cynthia Woodcock, who is the executive director of the Hilltop Institute at the University of Maryland, Baltimore County, which is a nonpartisan research organization dedicated to advancing the health and well-being of people and communities. Hilltop maintains a nationally recognized partnership with the Maryland Medicaid program. Ms. Woodcock chairs the steering committee for Academy Health State University Partnership Learning Network, which advances partnerships between public universities and state Medicaid agencies. Previously, Ms. Woodcock was Principal Research Associate for Long-Term Care, Aging, and Disability at Impact International, and has also held positions with the International Life Sciences Institute, the Commonwealth Fund, the Robert Wood Johnson Foundation, and the New Jersey Department of Health. Ms. Woodcock received an MBA from Columbia University and a BA from the University of North Carolina, and we are so pleased to have both of them here with us today. And the presentations will start with Susan, and we will move directly into the presentation from Cynthia, after which I will help moderate some Q&A. So please put your questions as they occur to you in chat or the Q&A, and then we'll bring some of those into discussion for the last 15 minutes of this presentation. So thank you very much, and we'll move into Susan's presentation. Thank you.
Thank you very much, Sarah. It's a pleasure to be here with all of you, including my colleague, Cynthia. We're very excited to have this opportunity, and I'm especially pleased to harness really this unique time we're in. I know it's not ideal with the pandemic as a backdrop, but it allows for us to really elevate the conversation about how evidence can inform critical policy making. I really think there's no time like the present to spotlight the role of evidence and how it has played and can play moving forward into the next year. I certainly want to shy away from any political commentary, but I do think that during the time we're living in is a perfect example. We're really seeing a different value being placed on scientific evidence, and the impact of that is really directly being felt across communities. You need not look any further than our federal administration or that of different states and local communities to see how contrasting value and willingness to apply evidence can inform policy approaches to protect and limit exposure to COVID. Simply put, evidence and its use or lack thereof is impactful. And I believe for those here today, we know this to be true. What we may not know, though, is how states and researchers can collaborate to produce and apply quality, rigorous analyses to inform policy decision-making for the health and well-being of the communities and our individuals. Next slide. So really across this nation, I chose this slide to represent the diversity of Americans today, and of course policies that affect them, recognizing that all these characteristics are not exclusive to one another. So there's geographic regions like where Cynthia and I live, and across all the way to beautiful Washington state. There's also real income differentiations and race, ethnicity, age, and workforce type. So we're all struggling in some form or another as a direct or indirect result of this pandemic. And so from every corner of this crisis, there's likely a decision to be informed. Next slide. And these decisions can be really impactful by partnerships between the State House and their governing agencies and state universities. I think leveraging the relationship between these two is why I'm here to talk to you today and hope to illuminate on that value. Also recognizing, thanks to Sarah, I tried to include some of the local universities in Washington state, but by no means meant to exclude any if you do not see a logo of your own university. Next slide. So give you a little bit of background around Academy Health. We spent a lot of time talking about these relationships between research producers like university researchers and users. Those are the policymakers or decision makers. We're a large membership organization of over 4,000 health service researchers, and we strive to work together to achieve a world where evidence informs these decisions for the optimal health for all. We strive to achieve this through our mission to improve health and healthcare for all by advancing evidence to inform policy and practice. And you'll see this mission also translates down to the state university partnership, which I'll talk about in a bit. Note, across our vision and mission, evidence is the common denominator here. It's important, it's a common good, and truly the diversity of opinion and perspective makes for better evidence. And this is ever more apparent and important in the time we are living now. Next slide. So as Sarah announced, I can share a little bit about the role that I play at Academy Health, the Evidence Informed State Health Policy Institute. This institute oversees a variety of state-based networks, and really they all strive with a similar mission. But under ESHB, I really work to support and foster a community of state policy researchers and policymakers within the Medicaid policy space. In connecting these two, we at Academy Health really strive to help researchers create more relevant, timely, and translatable evidence, i.e. that evidence or information that is accessible and useful for policymakers so that they have the best evidence upon which to make these decisions. Academy Health supports this learning through two interrelated networks, as I mentioned. One is the Medicaid Medical Director Network, that's comprised of 42 state Medicaid clinical leaders, and the State University Partnership Learning Network, which I'm really here to tell you more about today. Both networks do support peer-to-peer shared learning and even cross-learning across the two networks. And as for the home networks themselves, our role, please, next slide, is to support their efforts in evidence production and dissemination. And that's a critical element that we serve here. So we do this by the following examples. One, we support cross-sector collaboration between both state Medicaid stakeholders and other sister social service organizations and providers. We help equip Medicaid researchers and policymakers with the tools to assist in implementation of these policies. And as I mentioned before, we strive to advance the quality and applicability and availability of the methods and data sources to assist in using research. And lastly, but certainly not insignificant, is disseminating health service research, which we're really turning and focusing on now to inform those state decision makers on policy practices. And then overarching to all of that is that here at Academy Health, we strive to provide strategic direction and coordination and management of those projects across the two networks. Next slide. And today, as I mentioned, I'm going to talk about the State University Partnership Learning Network. It's a mouthful, but we affectionately call it SUPLN. Cynthia has been around longer than me with respect to the creation of the network, and she can share whether everybody intended it to be to stay as SUPLN or to have changed. But I think we've all embraced it now. So SUPLN's core mission is to promote the use of evidence-based policy to support and strengthen this policy making and practice for both, as I mentioned, predominantly Medicaid agencies, but also their collaborating agencies. We're seeing more and more of that now. See on this map here that we have a network of, it's 26 states are highlighted here, but it's really 30 established state partnerships, as some of these states have more than one partnership with their universities. So these partnerships are between a state governmental entity, as I said, primarily Medicaid, and a state or state-related university research center. Among the key principles that guide the SUPLN, one that is particularly paramount is the role that SUPLN sees themselves in terms of advancing themselves as trusted state partners, because their mission really is in the service of the states. And this is something that Cynthia, I'm sure, will speak to greatly. It is, in fact, that there are not particular ad hoc projects or desired research from the individual researcher, but rather it's the work they established work with the agencies that's guided by agencies' interest and policy decisions. And so they really do see themselves as a trusted partner. Also, their commitment to engaged scholarship, and also a deep institutional knowledge that they can bring to enhance the work of their state agency partners. Through this network, and you'll see this to the left-hand side of the slide, I tried to outline it here, we've really established a learning community of partnerships that foster sharing and spreading of best practices. And this is done so through facilitation of substantial dialogue between both the state government and the research centers to improve the partnership efficiency. We also support state government capacity building to conduct high quality policy and data analysis. And this capacity building works both ways. Again, Cynthia may speak to this from Hilltop. The capacity building for the state university is equally important in that it brings state policymaker expertise back to researchers to promote state considerations in their research questions and methods that they can help with respect to applying to policy analyses. Also provides an infrastructure for comparative studies across states. I'm going to talk about this in a second, but this partnership network has really expanded to provide this kind of consideration and modality for comparative studies. And last but not least, we really strive to build and strengthen partnerships and try to meet them where they are and help them grow. Next slide. So just to underscore, these partnerships, many with a rich history of collaboration, have been mutually beneficial to policymakers and researchers, obviously, as I've outlined here. But also, I want to underscore, ultimately beneficial to Medicaid enrollees and the community. Really, in summary, state university-born research can provide an immense value, also fostering capacity across the agencies and the universities. But this value continues to evolve to meet the growing need of the partnership, to meet the significant role of states who now serve and have served for a few years here now, as you know, to be the country's laboratories in administering Medicaid benefits with a level of flexibility to address the needs of their own populations and policy priorities. Most recently, the SUPLN published communications that convey this very value proposition of the partnerships. And this, you'll learn a little bit more in the next slide, but essentially, the value proposition works for both. As I mentioned, not only the value for researchers to their states, but their researchers and their researchers and the value of that partnership back to the leadership at the university. State university researchers recite again that they work in the service of the state. Next slide. So that these partners have a shared vision and trusted relationship. As you'll see on the right-hand side of the slide, this is just an illustration of the two communications that we have just disseminated. And I'd like to also acknowledge Cynthia as really the true author of these. It was really a group effort with the steering committee, but driven and guided by Cynthia here. So I'm happy to share those with the collab, and you can certainly disseminate those out. But anyway, in response to the value proposition, there is a shared vision and trusted relationship where the research is committed to providing analyses focused on everything from cost and outcomes to program analyses. Also, we bring researchers expertise in data science and advanced analytics. This is a skill that might otherwise not be built in-house at the Medicaid agency itself. And so bringing in these researchers allows for more rigorous evidence-based analyses to inform their policy. Additionally, as I mentioned before, there's a level of dependability and deep institutional knowledge. And I recognize that because at the state level, that staff may have a very expedited transition, whereas those researchers may be retained at the university for a very lengthy time. And so their knowledge is something they can bring back to the Medicaid agency, where the staff person might very well not be the same person that they worked with 3-4 years ago, and they therefore do not have that policy timeline of how policies have changed at the state level. Additionally, state university partners really have an understanding of lend an understanding of state health policy and agency needs. And so this is also a mutual benefit and value. As I mentioned before, the relationship itself will allow researchers to become more steeped in policy, the history of policy itself, as opposed to just the research methodology. And then the reverse is true. So for those Medicaid agencies, again, that might not be so steeped in the deep analytics and understanding the minutia of the, say, for example, the claims data or the encounter data, that's what the researchers can bring back to them. So it's a real mutual benefit. And then beyond the robust analytics that I just underscored, public universities often, like Hilltop, for example, can offer an additional advantage in terms of bringing expertise in IT infrastructure, data security, and workforce training, again, that the states themselves may not have. So I'm going to pause for a second and just pose for any of you out there that may be policymakers in attendance. Would you rather look at data on another population, like another state's population, in a different context with potentially different policy environments to help you make decisions about your own community, state or local? Or would you rather consider your own state-specific information guided by rigorous analytics and knowledge sharing when making critical decisions that have a great impact, again, on your statewide or local community? I think Supplement members would say we choose the latter. They see the value in that, certainly at the Medicaid program level. And I want to share some examples of how that state-based research is helping overcome persistent policy challenges. Next slide. So to give a background to this, I think through the implementation of Medicaid waivers and demonstrations, you're going to see that state Medicaid agencies and research partners have really been primed to consider more established, sustainable analyses in terms of improving insurance coverage, increased access, and enhanced care quality. I think prior to the pandemic, states were already faced heightened expectations from their own state leadership as well as CMS for delivering high-value care, increasing the need for rigorous evidence-based policy and program analyses. But I think now the need is ever more important for population-specific and timely impact analyses, especially related to COVID. The following examples here really highlight the role supplement partnerships serve in generating that research to inform Medicaid policy and practice. So the first one here highlights the Commonwealth of Pennsylvania. The state sought to assess the quality of opioid treatment for their Medicaid beneficiaries, and research provided by their partners at the University of Pittsburgh's Medicaid Research Center informed the monitoring and evaluation of their health homes, which they called Centers of Excellence. This research showed that improved retention in treatment could be enabled through access to critical follow-up care and support within their own communities. So these Centers of Excellence coordinated care across providers and treatment that is team-based and whole person focused with an explicit goal of integrating behavioral health and primary care. The University of Pittsburgh's Medicaid Research Center continues to evaluate that program. The Commonwealth, the next one, the Commonwealth of Virginia's Department of Medical Assistance, where the Medicaid program is housed, has also called upon their partners at Virginia Commonwealth University to evaluate their 1115 waiver to address addiction and recovery treatment services. This is just one example of many of our partnerships where the university assists in either the design and or the evaluation of their 1115 waivers. Another example is in West Virginia University as well as Virginia Commonwealth, they have embedded data analysts right in the Medicaid programs. Now I know that this isn't always considered the best approach for some Medicaid programs of others, but I know that for these particular universities, this has worked very nicely to enable efficient data sharing, real-time access to Medicaid files, which has enabled results in up-to-date evaluations on Medicaid policy and program evaluations. Another one that I really wish to share that's of interest is New Jersey. Their policymakers are gaining real value from their university partners at Rutgers to help inform avoidable Medicaid spending among homeless persons. Rutgers State Center for State Health Policy has been working with New Jersey's Medicaid housing and mortgage finance agencies for many years now, linking statewide homeless management information system data with various Medicaid data sources to compare health service utilization among Medicaid enrollees who have experienced homelessness at some point in time. Now with Medicaid expansion, New Jersey Medicaid covers many more persons who have used homeless services, and Rutgers is continually evaluating the impact of that permanent supportive housing placements on Medicaid utilization and spending. I also chose to share some additional COVID-19 related analyses here, just to demonstrate that these research partners have been really truly engaged with their states to inform critical and timely care delivery during this pandemic. The two examples here, actually the first example in the second to last bullet, I can actually parse out into two, and that is that some states have shared, researchers have shared that they've conducted Medicaid member surveys to really assess their experiences in care prior to and during the pandemic, while other state researchers have looked at conducting provider interviews as well as surveys to assess their experiences with telehealth prior to and during the pandemic. Additionally, as you see here, evaluating impact of COVID-related telehealth policy changes on Medicaid beneficiaries. This seemed to be a common analysis as well that's been called upon by many state researchers. In addition to that, there has been, of course, monitoring of long-term care data for a variety of different enhancements and directing of services for COVID-related needs. So I believe these are all powerfully valuable, but I also wish to acknowledge the power of comparative state analyses. Although university partners have become a critical asset for state Medicaid agencies, single state analyses have some limited generalizability, especially when desiring to consider population-wide analyses due to variation across states in Medicaid benefit packages, eligibility criteria, payment systems, and so forth. So as a result of that, and recognizing some of the also challenges around, say, cross-state analyses, which recognize, could be very valuable. Next slide. Academy Health and Supplement partners, including Hilltop and the University of Pittsburgh, established the MODERN to provide, which stands for Medicaid Outcomes Distributed Research Network, or MODERN. We established MODERN to provide partners with an infrastructure to conduct multi-state Medicaid analyses to address issues that are of real import across the national public health policy landscape, such as the opioid crisis. It allows for measuring the impact of innovative policies and interventions on a much broader scale. I would like to share that the initial project, which we call the Modern Opioid Use Disorder Project, was funded by NIDA, and it's a 2.5-year effort to assess opioid use disorder treatment quality and outcomes in Medicaid. It allows for the informing of policy decisions on coverage and payment for evidence-based OUD treatments in Medicaid. And as you see here, in this map highlighted in gold are the 13 states that are participating, which again include Maryland and Hilltop, and those states that have been the hardest hit by the opioid crisis. So perhaps Cynthia will talk about this a bit later. But just to underscore, Modern really builds on both networks with an infrastructure and governance informed by well-known federally funded distributed research networks. If anyone is familiar with PCORI's PCORNet or the FDA Sentinel, both of those DRNs informed the development of the Modern. And I just want to underscore what is so unique about the Modern, similar, sorry, to the Coronet and Sentinel, but allows for Medicaid cross-state analyses. And that is that these analyses allow university researchers to conduct standardized Medicaid data analyses locally. So they're using their own state Medicaid data, which is very comprehensive, and it then allows them to share only the summary results, not in personal data, back to what we have as a data coordinating center currently being run by the University of Pittsburgh. The University of Pittsburgh then aggregates and reports those results back out to their states. And so I just wanted to share how that works. And again, that really eliminates any concerns around, or should I say, likely eliminates most of the concerns around data sharing and security. Now, this project has produced an immense value to participating states, as well as others who might benefit from the analytic infrastructure established, as well as shared learnings. I will say we are continually considering what other policy areas might be of interest. A good example would be around maternal health and severe maternal morbidity. Last slide. So, like you all, I could talk about the critical value of evidence and the continued need to emphasize this value, as well as give you additional examples of how state partnerships work. But I know you're all here to understand that and ensure the health and well-being of communities and families through the use of evidence. So I'll bring this circle back to Academy Health's mission, one that I think we can all share. And that's, in order to ensure the optimal health for all, we really need the best data, the most localized data, as well as the most familiar and localized researchers to inform the most applicable policy decisions for your community. I think the local connection is what makes these state university partnerships the best match. And I think that Cynthia will share exactly why that is.
Hello, everybody. I'm Cynthia Woodcock, really glad to be here. And I'm going to talk about the value of Maryland State University partnership. And on my slide here, the flowers are black-eyed Susans, which are our Maryland state flower. So a little bit of Maryland there for you. We can have the next slide, please. So I'm going to tell you a little bit about Hilltop, our mission, competencies, and how we're organized, our clients and collaborators, what kind of relationship we have with Maryland Medicaid. And then also, I really want to talk a little bit about how the Maryland Medicaid Hilltop collaboration embodies the value proposition for state university partnerships. As I worked on drafting those value propositions that Susan referred to, I was really looking back at our very personal experience with the Maryland Medicaid program and also my supplement colleagues. And so I think you'll see, how those play out in real life through my presentation, hopefully. That is my goal. Next slide, please. So Hilltop was established in 1994. We had a different name then, but I won't go into that. We are one of the largest research centers on the UMBC campus. And I might add that UMBC is part of the University System of Maryland. Our really big flagship university is the University of Maryland at College Park. They're the ones with the football team. We're the ones with the chess team. That's a champion chess team. And UMBC, we also have the University of Maryland, Baltimore, where the professional schools are, our medical school, law school, pharmacy school. We do a lot of collaboration with them, as well as College Park. So our mission is we work to advance the health and well-being of people and communities through research and analytics. Our vision is to be a preeminent resource for federal, state, and local policymakers, although our focus is mainly state. And I highlight a part of UNBC's mission here because it's teaching and research, which is the case for all universities. But in addition, service is a very important part of UMBC's mission, and it's specifically service to benefit the citizens of Maryland. And this is actually from the mission statement. And Hilltop very much embodies that role of the university. Next slide, please. So who are we? I mentioned that we're a research center on the UMBC campus. We're a little bit of an oddball out on campus. We're all staff. We have no faculty, although some of our staff have affiliate faculty appointments. There are about 50 of us, so we're pretty big. And we have students coming in too, that in and out, interns and research assistants all the time. But a mix of health services researchers, social scientists, public health people, economists, financial analysts, attorneys, SAS programmers. We're a SAS shop. And our areas of expertise are data analytics, and I might say it's data at Hilltop. We do a lot of work around healthcare access and affordability. We do rate setting. I'll tell you a little bit more about that. Aging and disability work, behavioral health, social determinants, and we have a hospital community benefit program too, which is probably a subject for another day, but it's an interesting program. Next slide, please. We're guided by an advisory board. And this is a rather new development. We've only had this board for about 2.5 years now. It was about 4 years in the making. My boss, who is the vice provost, this was one of my things when I came on as executive director. It took me a while, but now I'm telling him, okay, I want an excellent rating on my next performance evaluation. We did this and it's been spectacular. Chris Kohler is from the Milbank Memorial Fund, is the chair of our board. And he's also a very important partner to Suplin and Academy Health. And then we have a number of other people from the public and private sectors. And it's really been good in helping us look at strategy and how can we expand our reach? How can we improve what we do in the state? So it's really been great. Next slide, please. So this is a slide I like to show that it lists our core competencies. And then it also highlights that service to the state of Maryland, which you see right in the middle in the list of teal colored boxes. So our core competencies, as I mentioned, we're data people, we're data analytics people. We have a huge data warehouse, which I'll tell you more about. We do very sophisticated analytics. We have knowledge of state health policy. We have the university resources we draw on. And then we are this exemplary state-university partnership. We're one of the first, and we're one of the founding partners of Suplin. That goes back to, I guess, 2016, but we all had thoughts about how to form something like Suplin for many, many years before that. So anyway, service to the state of Maryland is our central focus. And you can see at the top, research and engaged scholarship. So we are on a university campus. We are engaged in research, but we're really looking at that research to feed back in and benefit the work that we do for the state. Similarly, we are trying to reach a more national audience since we do tend to be very state oriented. But on that front, that's part of our Suplin strategy. So we're working with many of the other Suplin states, as Susan said, on the Medicaid Outcomes Distributed Research Network. We're doing some cross-state research work. Other Suplin projects have come to the fore that we've been involved in, where it's multi-state. And then we also are, this is kind of an aspirational goal, we're trying to get positioned more to provide some technical assistance to other states that might want to develop their data and analytic capacity. So that's one of our strategic objectives that we're working on. Next slide, please. So this is our list of clients and collaborators. And the very first one is the Maryland Medicaid program. As I said, our relationship goes back to 1994. Very long-standing, and we have an annual contract, or it's an interagency agreement with Maryland Medicaid, have had one since 1994. It is pretty much our core funding. But in addition to Medicaid, we work with a number of other state agencies, either working kind of in collaboration with Medicaid, or sometimes working more independently with those other agencies. And Maryland is an interesting state. We have our total cost of care model. And I don't know how many of you are familiar with this, but we're the only state in the nation that regulates hospital rates. And we have a model, all the hospitals are operating under global budgets. It's also an all-payer system. So all payers pay the same amount for hospital care. And then our most recent agreement with CMS it's called the total cost of care model. And we're really focusing on improving population health in the state. The hospitals are being charged with improving the health of their local communities. Right now, we have performance measures built around Medicare for the feds, but Medicaid is going to be coming in behind that. We're going to have population health measures, first around diabetes and some other issues. So it's a very interesting state. So Hilltop is into the total cost of care model in a lot of ways. For example, for Maryland Medicaid, we developed the methodology for calculating total cost of care for Medicaid. And that's been used to help inform how that's done for other payers. So anyway, we work in that environment. Another part of the total cost of care model is the Maryland Primary Care Program, which started up about 1.5 years ago. It's very similar to the CPC Plus programs that some states are operating, but it's all tied in with the total cost of care and trying to, keep a lid on cost, better manage care for people in the community. And there we've developed this very sophisticated model to predict the risk of hospitalization. And we actually produce on a monthly basis now risk scores for individual Medicare beneficiaries who are attributed to practices participating in the Maryland Primary Care Program. And those risk scores are sent out to the practices via CRISP at the very bottom of the slide. It's our health information exchange. And the practices receive them and care coordinators get them and can help manage the patients in their practice. They can highlight people who are most at risk and hopefully try to get some services to them. And right now, that program is reaching 345,000 Medicare beneficiaries, about 470 primary care practices, and about 2,000 providers. So we're active in that. I've listed on this slide some other agencies that we work with within the Department of Health, the Public Health Administration, Behavioral Health, the Developmental Disabilities Administration. Also other Maryland agencies, I've listed the Health Services Cost Review Commission, which is the hospital commission doing the total cost of care model, but also the Maryland Healthcare Commission, which is charged with a lot of regulatory activity, certificate of need, also ensuring information gets out to consumers on nursing homes and things like that. The Maryland Health Benefit Exchange is our marketplace, our ACA marketplace. We have a state marketplace. And we actually helped get the Maryland marketplace set up. We did a lot of the initial work working with stakeholders, the initial report to the Maryland General Assembly recommending it be established. And since then, we've been doing all kinds of policy work. We cranked the numbers behind the reinsurance model that the state implemented last year that has resulted in significant savings in premiums for people enrolling through the exchange. So anyway, lots of activity throughout the state. Next slide, please. So talking a little bit more about our relationship with Maryland Medicaid and what we do. I mentioned rate setting. We do this very differently in Maryland. Health Choice is our managed care program. It has been in operation since 1997. One of the things that got Hilltop started was we actually wrote the waiver for the Health Choice program to CMS. And after that was approved, kind of being in the right place at the right time, Hilltop was called on to do the rate setting for Health Choice. And we've done it ever since. And today it's 1.2 million beneficiaries, 9 health plans, $6.5 billion worth of capitated payments. We have an annual rate setting cycle that's very interactive with the state and the managed care plans. We do, a whole host of analytics. We do risk adjustment. We've had individual risk adjusted rates for everyone in Medicaid that we develop. We do have consulting actuaries that we work with who actually certify the rates for CMS, but it's a very collaborative process with the state, Hilltop, and the actuaries. Very unusual model. It's a cost-effective model. Many states just contract out to actuaries at much greater expense probably, but it is a big role we play. And because we started playing that role, you need data to do rate setting. So we began developing this huge data warehouse, which we still have. We have all of the Maryland Medicaid claims and encounter data back to 1991. We have it in-house in a very secure HIPAA environment. And a host of other data sets that I have on my next slide. But anyway, we do a lot of rate setting, a lot of other analytic work and evaluation work for the Health Choice Managed Care Program. We do all kinds of other analytics for the state. A lot of it's quick turnaround. You know, we get a call at 10 in the morning, we need it this afternoon. Right now, we're working very busily on some information on providers that are getting extra payment through the CARES Act. CMS wants something by midnight tonight. And so the team is really working hard getting that out. Maryland has some health homes. We do the evaluation of those. Community First Choice, we helped with the implementation, development of individual budgets. We've helped with some strategies around dual eligibles. Maryland has not gone in a big way into managed LTSS or any of the duals demos, but we've been looking at possibly a PACE expansion, possibly an ACO for duals. So we do all of that kind of work for Medicaid. Next slide, please. So our data warehouse, I mentioned, it's quite huge. So we have all the Medicaid data, we have Medicare data, various kinds of Medicare data, hospital discharge data, vital stats data, nursing home minimum data set assessments, NRI, home care assessments. We have the all payer claims database for Maryland. We've got really very extensive data. And we're very skilled at matching it at the individual level. All the data we have is identified at the individual level. So it really is very powerful what we can do in matching. We support, we're developing and support Dataport, which is an interactive dashboard for Maryland Medicaid. It's a decision support system, very specialized for what Maryland Medicaid wants for its internal use. We also fulfill data requests from external researchers on behalf of Medicaid. Many researchers go to the department and say, we'd like data for this study. And then we work with the department and the third party to develop data use agreements and contracts, and we deliver the data to them. We're also always on the ground ready for crises. I mentioned the one that we're working on today with some provider relief payment data. Well, COVID-19, we've been in there scrambling, doing everything from providing staffing support for the hospital surge task force. We have daily calls with them. There are daily reports we're putting out on hospital capacity and ICU capacity and all of that in the state. We're monitoring testing and deaths in the Medicaid population. We're actually getting testing data from CRISP, our Health Information Exchange. We help the state draft waivers and state planned amendments and all of those special relief actions that the states were all doing right at the beginning with CARES. We've been monitoring use of telehealth, big issue in the state as it is everywhere else. Also behavioral health and long-term care utilization. And then on the rate setting side, we've been working with the state to develop a global risk corridor for the managed care organizations. Since as everybody is experiencing, people are not getting the care as anticipated. And right now the managed care organizations are getting a little overpaid this year for the care they're providing. So we're working on the risk corridor to help adjust some of those payments. So that's the tip of the iceberg. On to the next slide, please. So I think it's important to say that our relationship with Maryland Medicaid starts at the top. And on this slide, I have kind of the key hallmarks of our relationship with Medicaid over the years. And with the relationship starting at the top, Robert Neal is our Secretary of Health. And then on the right, you have Freeman Abrowski, our president. Freeman was instrumental in getting Hilltop established back in 1994, working with the then Secretary of Health. Again, Freeman sees our mission as service to the state. So very strong support from the leadership. Secretary Neal is also on the Board of Regents for the university system and is the assigned regent for UMBC. So we have a lot of multiple relationships going there. And I mentioned we build on UMBC's mission of public service, a lot of shared goals. And then with the Department of Health and Medicaid, very much a joint commitment to data-driven policymaking. We're really, the data behind the policy in Maryland. Flexibility flexibility to respond to changing needs, just that project we're working on today, generating that extra provider relief data. That's what we're here for. Continuity and cost effectiveness. We're here, we've been here for 26 years. We're not going anywhere, hopefully. We're also very cost effective compared to private consulting firms. So those are kind of our general value proposition items. And going on to the next slide, please. So we also have a very deep bench. It's what I call us at Hilltop, our 50 staff. Very deep knowledge of state health policy, deep institutional knowledge, longevity. A lot of us have been around a long time. I've been at Hilltop a cumulative 14 years, not all of that as executive director. We have staff who started as undergraduates and are now director level with 20 years behind them at Hilltop. They've never worked anywhere else. We help support some cross-agency cooperation on important research and policy questions. I mentioned that we work with a lot of different state agencies, and sometimes we'll be working with the Department of Human Services and say, we think that's a question for Medicaid. Let us talk to our Medicaid people and get you guys together, talk about this, and then we can figure out how to solve it. We do a lot of that. Constancy during state government transitions. We're the stable research and analytics arm when the administration changes, every 4 years or so. And we're at the ready during crises, as I've already talked about with COVID and OUD, other crises that come along. Next slide, please. So it's also contracting made easy. So we work under interagency agreements for the most part, so that no competitive procurement is required for our main agreement with Maryland Medicaid. We also are able, or Medicaid is able to take advantage of the federal Medicaid match to help pay for our services. We're actually a line item in the Medicaid budget. We're a much lower cost alternative to a private consulting firm. We're also, from UMBC standpoint, all of our agreements are a very reliable source of revenue for UMBC. We bring in a lot of overhead. We're a totally 100% self-supported research organization on campus. But we, do have to bring in the overhead for the university. And right now it's really helpful as the university is facing some pretty significant budget crises, as many universities have. And we've been most fortunate in that our revenue has been very stable throughout all of this, and hopefully it will remain that way. Next slide, please. So cutting edge data analytics, I've already given you a lot of examples of the kinds of things that we do. The Dataport interactive dashboard, which is our decision support system for the department. Some of the predictive modeling. We've been developing a host of predictive models to predict the risk of adverse events such as hospitalizations. We now have some special funding to develop one for risk of hospitalization from COVID-19. Hoping to put that into production very soon, working with the primary care practices and hospitals. We've also done one for risk of nursing home admission, which is being used as part of the decision-making for the Medicaid home and community-based services waiver slots. We have a waiting list in Maryland to get into a waiver. And so in addition to first come, length of time on the waiting list, the factor from a brief assessment of risk of nursing home admission is entered into that equation. And then we also have this, I just mentioned, a very secure and HIPAA compliant IT infrastructure that UMBC supports. I think this is one of the benefits to the state, that we have UMBC behind us, which is very strong in information systems and computer science. We're the nerdy campus, the chess players, the computer scientists. So we can offer really that very strong infrastructure to support all of this data work that we do in the data warehouse. So next slide, Susan mentioned engaged scholarship. And I think we're a very good example of how that is done. And when someone first mentioned this term to me, I wasn't sure what it was. So I looked it up, and there's actually a whole science or whole literature around it. And so it's really what a lot of us have called applied research. So it's collaborative inquiry between academics and practitioners that leverages their different perspectives to generate useful organizational knowledge. So I like to think of it as kind of that interactive process between us and state agencies. And there's a lot of interactive learning back and forth, and we can bring evidence and put it into action, get learnings from that, bring it back in, build better evidence. So it's a constant learning circle. Next slide, please. So, in terms of our engagement in scholarship, engaged scholarship, I think it's very much engaged scholarship in action. And, we are these trusted partners in problem solving. We collaborate via this continuous two-way flow of evidence and information I was just talking about. We also, being university-based, bring academic rigor and objectivity balanced with this policy knowledge and sensitivity and an understanding of the local environment. And then our engagement in academia ensures that we're using the latest scholarly methods and evidence to inform policymaking. We have all these faculty that we work with, connections with faculty on everything from social sciences to methods, work, you name it. And we really go to faculty from UMBC, from the professional schools, also from Johns Hopkins, frankly. We work with Hopkins researchers quite a bit. We've been active in many, many areas: COVID-19, opioids, population health, violence prevention, social justice. So we really kind of broaden the work we do and evidence base that we're creating. So I think that is my last slide. We go to the next. Yes, this is just Hilltop. So anyway, thank you very much.
Thank you so much, Cynthia and Susan. That was a fantastic overview of all the amazing work happening in Maryland and then with Supplin nationally. So there are a couple questions here, and I think the first one we can direct to probably Susan. How can we find Supplin contacts for any given state? Can researchers join or access without going through state Medicaid directors?
Yeah, so that's a great question. Actually, I invite you to just email myself, and I'll also copy our research associate, our research assistant rather, for Supplin. What we can do is, depending if it's Washington State, we can share with you via, like an email connection, which is always usually nice to make that connection and share that with you. And not in every state is it a for the most part, it's a Medicaid person, but it's not necessarily a Medicaid medical director. It really depends on the state. So happy to do that if you want to. I know that my email address was at the end of my slide deck.
Great. And maybe, Sally, we can pop back to that so folks can see it on the screen if you want to go back to that slide. And then Cynthia, possibly for you here, in your partnership with the Maryland state government, does Hilltop use an indirect rate different than its FNR? And if so, how was that determined?
Yes, so our federally determined rate, there's a research rate, and then there's an other sponsored programs rate. And we typically use the other sponsored programs rate. I think our research rate is 53 something percent. The other sponsored programs is 28%. However, we have negotiated that downwards with Maryland Medicaid because of, our ongoing relationship. And it's at around 25% now. So yes. And are we a land grant university? I can answer that one as well. I don't think so. We're a state university. We're a public agency, but I don't think we fall in with the land grants.
Okay, great. And then just a couple other questions here. So going back to the rate setting, Cynthia, can you speak a little bit more to the benefit of incorporating the risk estimates into the rates for total cost of care? So for example, has Maryland already seen benefits that potentially affected workforce retention or client outcomes, or is that work in progress?
I would say it's very much a work in progress. With the total cost of care model right now, our performance measures with CMMI are really focused on Medicare only. Their cost measures that we have to meet, cost targets, and also some of the avoidable hospitalization type measures. In the next couple of years, we are supposed to kick in having to comply with measures for Medicaid. And then down the line, I'm thinking, the total cost of care, which would include commercial payers as well. I think the jury is still out on how much it's going to, trickle down to the community level. There are some special programs that the Hospital Commission is working to try to get the hospitals to collaborate more with post-acute providers, and then hopefully trickling down. But one of the issues with Medicaid is to what extent might the hospitals start shifting costs down to Medicaid, out of the hospital setting, because they're really judged on hospital metrics right now. But yeah, it's a model to watch. No conclusive findings. There are a lot of evaluations out there looking at different things, and they're all worth looking at. But I would say there's no one general conclusion yet.
Great, thank you so much. And then Susan, you spoke about the desire to have the information network across multiple states. And I know this is putting you on the spot a little bit, but can you think of a state in the network that was able to use research from a different state to inform some policy making in their state? And if nothing springs to mind, that's just fine.
Well, actually, I would say that the modern opioid use disorder project could be a good example of that, only in that those comparisons, I think, and Cynthia, you might be able to shed some light on how Maryland has interpreted that. But when that collective data has been shared for some states, seeing some of the difference in outcomes for other states more positively has helped them make decisions in a pretty fast order to their opioid treatment approaches. So I want to say Kentucky was one of them, but I can't, for right now, I can't for the life of me remember which particular policy, but I can share that those that particular data from other states was compelling enough. Again, probably because the data was able to be standardized, so they felt like this was in some ways applicable again to their population.
That's a great point.
Yeah.
And Cynthia, did you want to say more about that?
Yeah, it was interesting because we got some of the results from Modern. I think early on it was 8 states, and the states were all blinded. And I shared them with our Medicaid leadership. And I was able to tell them which one was Maryland. And Maryland actually looks pretty good compared to some of the other states. So it made our state feel like, they were we still have a long way to go, but, it gave them a pat on the back saying, you're moving in the right direction. So that was
some
good.
Encouragement. That's great.
Yeah, but I think, the work we did with Virginia, so Virginia's part of Modern as well. And they only, I think it was last year, started their Medicaid expansion, but they started a couple years before that, a really exemplary behavioral health program. And so, comparing, and we did a joint study with some Robert Wood Johnson Foundation funding, looking at implementation of our 2, we each have waivers for institutions for mental disease, to be able to get Medicaid reimbursement for it. And so, I think, looking at the 2 states and how we're so different, but I think Virginia could see how they're very easily catching up with where we were on some things. We saw things they were doing that, we probably could have been doing better. So I think it's been very helpful.
Wonderful. Well, thank you so much to both of you. And thank you for the folks that stuck around here to the very, very end. We're going to be sending out emails with surveys about the kinds of topics that people would like to hear next, and any feedback you have on this. Thank you again, Susan and Cynthia, for your time. This is incredibly helpful and interesting.
You're welcome.
Thank you. Yeah, glad
Have
to
a
be
wonderful weekend. Bye.
Bye.